Okay. So topic given to me is targeting EGFR exon 19 and exon 21 L858R mutations in new era. So the question which is standing in front of us is L858R a different disease from deletion 19? This is what the question which is standing in front of us. And if we are able to answer this question, I think the purpose of my presentation will be over. So covering this topic in 15 minutes is an overstatement, but I will try to do justice with the topic. So personalized therapy with the EGFR TKIs, the timeline development, we know that the first FDA approval got from 2003. That was the first Geftinib TKI which was approved, and followed with there was plethora of options which over a period of time have opened up. And there was anticipation in the medical oncology community when Geftinib came into existence that there are many more drugs which are going to come in EGFR basket, and we'll be having a lot of options. And this came true also. And right now we are having more than 5-6 options as far as EGFR targeted treatment is concerned. So first generation, second generation, third generation, we know that erlotinib, Geftinib are the first generation reversible inhibitor which are inactive at the T790 mutant, and afatinib, decoratinib, the second generation EGFR inhibitors, which are also irreversible covalent binding to EGFR, HER2/neu, HER4 to inhibit all the ERBB family signaling. They are having broader activity to overcome the EGFR TKI resistant mutations. Osimertinib, this is a third generation EGFR inhibitor, which is specifically acting on EGFR T790 mutant and EGFR wild type sparing activities. There is also irreversibly covalent binding to the mutant EGFR. So before 2000, we were having only best support TKI or single or doublet chemotherapies. 2000 onwards, we are having first generation, second generation, and third generation. So what is the PFS and overall survival benefit? What is the treatment evolution in EGFR landscape? So Geftinib came with a PFS advantage of median PFS of 10.8. Then erlotinib was 9.7 months. For afatinib, it was 11 months. Decoratinib, it is 14.7 months. This is median. Overall survival also for decoratinib was 34.1 versus 27 with the standard of care arm. Hazard ratio of 0.76. For osimertinib, it is 18.9 months. Flora data we all know. And overall survival also published, it was 38.6 months versus 13.8 months, and hazard ratio of 0.799. And one more thing I want to highlight, that Asian population, the median oral survival for decoratinib was 37.7 months, and for osimertinib, the oral survival was 1 for those. Hazard ratio was 1 for Asian population. So it was not statistically significant for osimertinib in Asian subset, although the median PFS was equivalent for decoratinib and osimertinib, that is 16.5 months. So progression-free survival for single agent TKIs, we are having LUX-Lung-7 trial, Archer 1050, and Flora trial, in which median PFS, as you know, it is 11 months. For afatinib, for Geftinib, it was 10.9. For decoratinib, is 14.7 and 18.9 for osimertinib. Archer 1050, which is a trial for decoratinib, which has shown that the median PFS, as you can see in the Kaplan-Meier curve, it was 14.7 months. With Geftinib, it was 9.2. That time, Geftinib was the competitor arm. Hazard ratio of 0.59. So that means it is statistically significant. Obviously, the patients have progressed later if they are used decoratinib for these mutations. LUX-Lung-7 for afatinib versus Geftinib, progression-free survival, as you know, it was median PFS was 11, and for Geftinib it was 10.9, so more or less same only. Hazard ratio 0.73. But you can see there the 18% of patients in afatinib were progression-free at nearly 2 years, and 8% for Geftinib arm. Flora data, median PFS, everyone knows, 18.9 months with standard of care 10.2 months, and hazard ratio of 0.46, and curves start separating. They are wide apart, favoring that it is favoring the experimental arm. We know that lesser the hazard ratio, better is the experimental arm, which favors osimertinib. Then came 2019-2020, that famous TMH data from Nirona v. et al., in which we have shown that when the platinum doublet was combined with first generation TKI, the median PFS was far better, and hazard ratio also significant. Median PFS for NEJ009, which was a Japanese study in which median PFS was 11.2 months, and hazard ratio 0.494. It was statistically significant. And for Geftinib versus Geftinib plus chemotherapy doublet, it was 16 months median PFS, and hazard ratio 0.51, favoring the platinum doublet with Geftinib. This was an Indian study from Norona et al. From TMH. Then first line TKI, if you put them in one line, that what are the median oral survival? By and large, if you can see, it was hovering around 25 to 34 months. But right now, we are having a lot of trials which have shown the median oral survival also have jumped over 50 months now. LUX-Lung-7 oral survival benefit, as you can see, afatinib and Geftinib, in which the median oral survival of afatinib versus Geftinib was 27.9 versus 24.5 months. Flora oral survival benefit, if we put it across with Archer 1050 for decoratinib, as you can see, it is favoring that those patients who are having osimertinib, the median OS was 38.6 months versus EGFR TKI generation, the leverage was 6.8 months and hazard ratio 0.799. For Archer 1050 overall survival benefit, it was 34.1 months for dacomatinib, and for geftinib it was 27. The leverage was 7.1 months. Hazard ratio 0.748 and p-value was significant. So mortality risk reduction was 25.2% for Archer 1050. That is a study for dacomatinib, and its mortality risk reduction was 20.1 months, 20.1% for osimertinib as far as FLORA data is concerned. So PFS and OS, if you can see the Noranatal, the median overall survival not yet reached, although the median PFS was 16 months, and for the Japanese study, it is 52.2 months as far as oral survival is concerned. And for erlotinib and bevacizumab, NEJ026 study, in which the median oral survival was 50.7 months and median PFS was 16.9 months. So there are lots of options right now. The median PFS, if we see that erlotinib was ramucirumab study, that is a relay trial, in which 19.4 months median PFS was there, although median oral survival not yet reached. And erlotinib bevacizumab also 18 months of median PFS is there, although oral survival have not yet reached. So these are the studies which are happening across the globe, and we should be well aware of that. If we put all the oral survival benefits for first-line EGFR targeted drugs, whether in combination or a single agent, as you can see, the median oral survival for the Japanese study is the highest, that is 50.9 months. For osimertinib, it is 38.6 months. For Archer 1050, that is for dacomatinib study, the median overall survival is 34.1 months. Hazard ratio is statistically significant. For FLORA, it is 0.80. For Archer, it is 0.76. Now coming to L858R, there is a higher incidence of concomitant mutations and poor outcome. So retrospective cohort study from China have shown that those patients who are having L858R mutation, they are having more likely of developing co-mutations. The ratio was 69 versus 41% as we compare L858R and deletion 19 respectively. So median oral survival benefit and PFS have not yet, median oral survival not reached, but median PFS was 18.77 months. So TMB was higher for L858R, which as compared to deletion 19. This is also a factor which we have to understand in the back of mind when we are seeing a patient of L858R. Deletion 19 deletion have shown that there are higher doses improve mean PFS and objective response rate in L858R, and this is what is depicted. The median or we can say objective response rate was 47.7% for L858R if we are using the lower dose, and if we are using the higher dose, it is 73.3 months, that is 73.3%. This is a very, very important slide in which we have to figure it out that how L858R mutation is different from deletion 19. So proportion of EGFR mutation, 40 to 45% will be on L858R as far as EGFR mutation is concerned, and 45 will be deletion 19. Locus will be A loop region in EGFR and alpha C helix region in EGFR in deletion 19. Clinical statistics, very, very important to understand. L858R, majority of patients will be older. They will be having more common on the right side of the lung. Lipidic growth pattern is more common, and lymph node metastasis is uncommon in L858R as compared to deletion 19, which is more commonly seen in younger age group, more common in left lung. Papillary type is more common, and lymph node metastasis is also common. The prognosis, we all know that for L858R is poor, and for deletion 19 is better. Malignant pleural effusion, which is 32.6% for L858R, and for deletion 19 is 26.6%. The frequency of other mutation is 69% for L858R, and for deletion 19 is 41%. Sensitivity to EGFR TKI is low for L858R, and for deletion 19 is high. So deletion 19 and 21 L858R mutations have different biological characteristics, clinical features, prognosis, as well as different sensitivities to EGFR TKIs. Therefore, there is a need to subdivide EGFR mutation, and individualized treatment of EGFR subtypes will be a key issue now and in future too. So coming to IC50, the minimum inventory concentration in nanomole values for dacomatinib for exon 19 deletion and exon 21 L858R substitutions are not very different. With IC50 values among lowest for dacomatinib compared with other EGFR TKIs for L858R. As you can see in the picture down below, it is 2.6, and for geftinib, erlotinib, it is 26 and 16 respectively. Afatinib also is 4, and osimertinib is 9. So this is the minimum inventory concentration at which this drug is effective. Now, putting the oral survival benefit in oral population and those patients with L858R, so dacomatinib has the same survival benefit in L858R exon 21 mutation population and the total population also. As you can see in the Kaplan-Meier curve, which is well depicted, that the median overall survival is 34.1 months with dacomatinib, and leverage was 7.1 months and compared to geftinib, and mortality risk reduction was 25.2. As you can see in the lower end of this curve, the patient continued to derive long-term benefit with dacomatinib. For oral survival with L858R, you can see that the median oral survival benefit is 32.5 months and hazard ratios of 0.665 and p-value is 0.0203, both sides. So obviously this is showing that this is going to work irrespective whether you are using in L858R or not. Flora, if we compare the Flora trial, L858R, you can see clearly that it is touching the line of unity and the forest plot, and it is not showing any benefit because hazard ratio is 1. So it is not favoring. So mortality reduction was 0. If we are using osimertinib, we can carefully look at the Flora data. For L858R, it is not the favorable drug, right? So concomitant therapy, as you can see in all the trials, NJ026, whether oral survival benefit. So A plus T, prolonged PFS significantly compared with TKI monotherapy in patients with L858R mutations, but which did not translate into oral survival benefit. There is no oral survival benefit. So this is the study in which L858R was compared. The combination therapy significantly prolongs PFS compared with TKI monotherapy in patients with L858R mutation, which did not translate into oral survival benefit, as you can see clearly depicted in this forest plot curve.
1 minute to conclude, please.
Yeah, so I will be quickly coming to a 60-year-old female patient. I will be putting a case with productive curve with good performance status. 3 centimeter nodule was there in the left lower lobe. Biopsy was adenocarcinoma, and there was no CNS symptoms. MRI have picked up 2 brain lesions, and mutation was EGFR L858R. So patient was started on dacomatinib by the data which we have listened on Archer 1050, 45 milligram OD. And reassessment scan was after 2 months, we showed objective response, and grade 3 diarrhea was the only side effect which was managed conservatively, and patient was continued with 30 milligram. Majority patients, like in this trial, also 66%, there was attrition because of the side effects. So as you can see, this is having good CNS penetration also, right? So this is what is predicted. There are so many multiple case reports which have shown that this drug is going to have a good effect in leptomeningeal carcinomatosis also. So I will quickly come to the safety summary. It is well tolerated. Majority times the side effects are diarrhea, dermatitis, stomatitis, paranoia. If we use the attenuated doses, we can manage that very effectively. Asian population is having the leverage, and there are so many studies which I will be skipping right now. But only last thing I want to convey that dacomatinib is a viable treatment option for EGFR mutation positive NSCLC based on the molecular and clinical data. EGFR 19 deletion and EGFR 21 mutations can be considered as 2 distinct subtypes of EGFR mutating drugs. Different EGFR TKIs have different role for EGFR 19 deletion and EGFR 21 mutations. Therefore, treatment strategies for EGFR 19 or EGFR 21 should be benchmarked on comprehensive analysis based on efficacy, safety, and quality of life. Last words of wisdom that if we were not for greater variability amongst individuals, medicine might as well be science, not an art. And he who studies medicine without books, sales, and uncharted see, but he who studies medicine or medical oncology without patient doesn't go to see at all. Thank you very much for your patient listening.